We will move on to welcome address by ISA Kanyakumari President. He is not able to join today, so I request Dr. Anand Kumar. He is the past president of our ISA Tamil Nadu to give welcome address as well as felicitation speech. Dr. Anand Kumar, please.
Thank you. Thank you. Can you hear me?
Yeah.
Yes, sir.
Namaskaram, everybody. First of all, I welcome all the delegates to this webinar and the speakers, Dr. Selva Panchacharam from UK and Dr. Nishal Perumal from Kanyakumari ISA, working in Jayasekaran Medical Trust. And the moderators, Professor Dr. Kannan and Professor Dr. Pankaj Kundra. I welcome you all, sir. Then, by the way, I congratulate all the state office bearers, President Dr. Sudasan, Secretary Dr. Kirbaharan, incoming President Dr. Kumar, and Treasurer Dr. Ratna Kumar for this wonderful job during this COVID period. All the
Dr. Kannan, please unmute yourself. Mute yourself. Kannan.
Kirbaharan, can you hear me?
Yeah. We can hear.
Yes, sir.
Yeah,
Yes,
I really congratulate all the office bearers of the state ISA, the President Dr. Sudasan, Secretary Dr. Kirbaharan, then Treasurer Dr. Ratna Kumar and incoming President Dr. Kumar for all this wonderful job during this COVID period. I'm really thankful to them because they made once again, they involved each and every branch, and conducting a weekly webinar is really a very tough job. They are also very busy practitioners. Really thankful, all of you. Then regarding my branch, that is Kanyakumari ISA, you all very well know. Then Treasurer Dr. Ratna Kumar and incoming President Dr. Kumar for all this wonderful job during this COVID period. I'm really thankful to them because they... Hello?
Yeah, audible, sir. Audible.
Hello?
Yeah, audible. Yeah.
So in our branch, it's really active. You all very know from Subramanian sir period itself, it's very active. We reached near getting this state national award for our branch twice and missed it in a very few points. And this reason, the office bearers, our President, Dr. Vijayan, Secretary, Dr. Rajshekhar, Treasurer, Dr. Anand Karthik, and incoming President, Dr. Daniel, they are doing a very good job. They nullified almost all the pitfalls, and we are almost ready and hope we will get it in near future with the support and guidance of the national office bearers and state office bearers. Once again, I thank you all. Long live IS.
Thank you, sir. Now I want to make a few announcements. Please note down this WhatsApp number. Can you able to see? Yeah. Please note down this WhatsApp number. If you need credit hour certificate for this program, you send your name alone to this WhatsApp number, not by SMS. Only your name by WhatsApp to this number. Please note it down. Okay. Now we will move on to our President's address, Dr. Sudarshan. I welcome Dr. Sudarshan to give his President's address. Before that, I recognize the presence of Dr. Kushela Babu, our past national president, and Dr. Bhimeshwar from and our GC member, Dr. Ganesh Prabhu. We welcome you all, sir. Thank you, sir. Dr. Sudarshan, please. Sudarshan?
Yeah, I'm there. Yeah. Good morning, everyone. Respected chairpersons, senior past presidents of ISA Tamil Nadu, National Office Bearer, Dr. Ganesh Prabhu. National Office Bearers, past President, Dr. Kushal Babu. Past Secretary, Dr. Bhimeshwar. Our past GC member, Professor Kannan. And our Tamil Nadu ISA past presidents, Dr. Muthukrishnan, Sellakumar, Ananda Kumar, and Dr. Kannan again. And respected branch presidents and secretaries, and all dear colleagues and members of various branches all over the state and from outside the state as well throughout the country. So this has become a habit for us. This is the 5th consecutive week we are conducting the webinar from hosted by different branches of the state. So it is primarily to instigate a good active response from each branch, because each branch, because of this COVID time, they were focusing on their own personal work schedule, and they were not able to gather together to organize meetings and interact with the state and the national office. So that's one of the primary reasons we started this, and it is going on well with the good support from everyone. And I see a good response every week. The numbers are going up. Last time we had close to about 560 people who joined and attended the meeting, and number is going to go up every week. So we are also working hard to get good speakers from all over, and good moderators, more importantly, who are senior professors who can take the session through. And with that little and I thank all of you to continue to participate in our weekly webinars. And then as far as we could, we will continue to host this. And also the credit points from ISA Medical Council is added attraction. So people are also wanting to, I think only state branch in the entire country to award continuous credit points, CME credit points from the Medical Council of India for every week program. That's another feather in our cap. I think with all these brief words, I congratulate ISA Kanyakumari branch for supporting and participating and hosting this event for us. And thank you so much, the chairpersons and the speakers for having taken time to join, especially Dr. Selva, who joined from UK very early in the morning. So over to Krupa back, and then the moderator, academic coordinator. Thank you.
Thank you, Dr. Sudarshan. Once again, I'm announcing that if you need credit hours for this program, send your name alone by WhatsApp to the number I already announced. We will send you the Google form and the bank details number, so you can proceed for getting the credit hour certificates. We will guide you. So now it's time to move on to our academic program. Today's academic program is coordinated by our Vice President, Dr. Kumar. So I hand over the program to Dr. Kumar to lead the academic session. Dr. Kumar, please.
Yes, sir. Thank you, sir. Respected National Office Bearers, our state GC members, Dr. Ganesh Prabhu sir, Dr. Balavenkat sir, our state office, our past persons of ISA Tamil Nadu, and today's moderators, and all the branch presidents, secretaries, and my dear colleagues. A very good morning to everyone. At the outset, I'd like to congratulate and thank our state office, though I belongs to the same, especially our president, Dr. Sudarshan sir, our very dynamic secretary, Dr. Kirubagaran sir, our academic coordinator, Dr. Edward Johnson sir, and treasurer, Dr. Ratna Kumar, for conducting this weekly online program in a successful manner as well as in a very appreciable manner for the past 5 weeks continuously. Coming to today's program, we have two interesting topics. The first one is about the Pre-Operative Fluid Management 2020. You all know that the optimal fluid management definitely improves the outcome after surgery, but there are controversies about the composition and volume of fluid therapy in the perioperative period. To clear these controversies, we have very eminent speaker from UK, Dr. Selva Panchacharam, who is a very eminent intensive care specialist come anesthesiologist working in UK. Help from the Madras Medical College. And the second topic is a very interesting one. Rheumatic heart disease complicating pregnancy in term with Colloids 5 pneumonia. During this pandemic, we are restricting the elective surgery. Though we are restricting, we have continued to take up the obstetric cases due to the necessity. To talk about this RHD complicating pregnancy in term with the Colloids 5 pneumonia, we have a very academically interested person, my good friend and a dynamic anesthesiologist from Nagarkoil, Dr. Nishal. To moderate these wonderful topics, we have very eminent, well-experienced and well-known academicians. Professor Emeritus Dr. M. Kannan sir from Tirunelveli and also Professor Dr. Pankaj Kundra from Jipmar Pondicherry. I don't think they both doesn't need any introduction for this august audience. For the sake of junior colleagues, about Dr. Kannan sir is a retired professor and HOD of Department of Anesthesiology, Tirunelveli Medical College, Tirunelveli. Is a past president of ISA Tamil Nadu State and also is a past governing council member of ISA National. He is a very good academician. Above all, is a very good-hearted and very humble person and always encourages youngsters to come up. Welcome, sir. About Professor Dr. Pankaj Kundra, he has qualified from the Government Medical College, Jabalpur, Madhya Pradesh. He has done his WHO fellowship in intensive care as well as in the pain therapy. He is currently the professor of anesthesiology, Jipmar Pondicherry, and also a dean academics, Jipmar Pondicherry. His areas of interest are pediatric anesthesia, intensive care, and pain therapy. Above all, he is a very good academician and a well-known teacher cum speaker. Welcome, sir. Before handing over the session to moderators, two announcements. One, the questions related to each topic, all the delegates can put up in the chat box. Number two, after completion of first topic, we will have the discussion and then we'll proceed for the second topic and its discussion. With this, I hand over the session to the moderators and requesting to proceed the session. Before that, I think Kribakaran sir wanted to talk and then proceed for the session. Thank you very much.
Thank you, Kumar. I recognize the presence of Dr. Chakra Rao, our past national president here, and our Tamil Nadu Medical Council observer, Dr. Ponraj. He is also a president of ISA Krishnagiri and Osur branch. We welcome you, sir. Thank you. We can proceed. Over to moderators. Dr. Kannan sir, unmute yourself.
Thank you, Dr. Kribakaran. And it is a great privilege to be a moderator in my dear ISA Tamil Nadu. I thank all the members. Am I audible?
Yes, sir. Very well.
Yes. And I am also honored by the presence of Professor of Anesthesiology, Jipmar Medical College. And he will be introducing the speaker regarding the Silva from UK, regarding the fluid administration and the update in this. We all know that fluid administration at any scenario is very important to maintain the homeostasis. And without homeostasis, tissue oxygenation is not possible. And by understanding the various pathology and physiological development, our fluid administration protocol varies from time to time. So today we have Silva from UK to update us the latest technologies of fluid management. And I request Dr. Pankaj Kundra to say a few words regarding the introduction of the topic and the speaker. Thank you.
Thank you, Dr. Kannan and Dr. Kumar. And thanks to the office bearers of the ISA and the past office bearers of ISA for giving us an opportunity to be here. It's my honor to introduce the first speaker, Dr. Selva Pancharam. He he's done his dual CCT in intensive care and anesthesia. He is at present a lead clinician for intensive care and also a consultant anesthetist and intensivist at Kettering General Hospital, UK. He has special interests in POCUS, which is point of care ultrasound and ICU. And he also has special interests in critical care, echocardiography, and perioperative medicine. It's an honor to will be an honor to listen to him. I welcome Dr. Selva. I think it's quite early morning there. Thanks for joining in. Over to Dr. Selva for the lecture.
Thank you very much, Prof. Kundra, for your very kind words. And it's indeed a great privilege and honor for me to be here in the presence of such eminent and great people. So I'll start sharing my screen. Can you all see my screen?
Yes, sir.
Yeah, we can.
Okay.
Put it in the slide.
Thank you. Yeah.
Yes.
Okay.
Yes.
I would also like to thank the Tamil Nadu ISA committee members for giving me the opportunity to present this talk. So this is my hospital, Kettering General Hospital in the UK, where I work. And these are my alma mater. So I did my undergraduation from Kilpatrick Medical College, and I did my post-graduation from the eminent Madras Medical College before I moved to the UK. So the topic I'm going to present today is about perioperative fluid therapy. It is a very vast topic, and due to time constraints, I'll try and keep it as brief and try and cover the important aspects of this topic. I do not have any conflicts of interest for this particular talk. So when we talk about perioperative fluid therapy, the first question that crops to our head is why is perioperative fluid therapy important? And that'll be the first part of my talk. And then I'll go on to the different types of the fluid therapies, as in maintenance, replacement, or resuscitation, and the choice of fluids we have at our disposal. Then I'll go to the last part of the talk, which is actually administering the fluids, how we do it, how to get it right in the three areas of preoperative, intraoperative, and postoperative periods. I'll also touch very briefly on the main physiological principles that underpin each of those three categories. So when we say fluid therapy, it is fairly obvious that we're not talking just about the water. It is the electrolytes that matter too. So very important to get that when we talk about fluid therapy. So answering the first question, why is perioperative fluid therapy important? Well, surgery is a very stressful period, not just for us anesthetists, but also for the patients. And as you know, major surgery causes a very high stress response in the form of a complex activation of inflammatory cascade, the coagulation cascade, the catalytic state. All these increase oxygen demand and put strain on the myocardium. So when you add an additional insult of hypovolemia, which reduces the cardiac output and reduces oxygen delivery further, it can compound the myocardial dysfunction. And when you add in other factors such as electrolyte imbalance, causing arrhythmias, once again worsens the myocardial dysfunction. And take hypervolemia, which is on the other end of the spectrum, as you know, increases the strain on the LV and also causes a whole raft of complications, particularly for abdominal surgeries, where it can cause anastomotic breakdown, post-operative pneumonia, etc. So ultimately, it results in organ dysfunction, which can worsen morbidity and mortality. So that's all good for physiology, but is there any evidence actually fluids do any harm? Well, there have been numerous studies published in this topic, and it will take all day to list them all, but the meta-analysis of randomized control trials of intravenous fluid therapy, this particular one, which compared a liberal fluid strategy versus a more conservative, or what we call as zero balance fluid strategy, showed there was definitely a significant improvement in outcomes with the zero balance fluid strategy. However, a word of caution with being too restrictive, as was shown in this trial, the RELIEF trial, where they compared restrictive versus liberal fluid therapy for major abdominal surgery. And what they found was there was, although there was no difference in the overall mortality, but there was an increased incidence of nephrotoxicity with restrictive fluid therapy. So do fluids cause harm? Yes, is the obvious answer. However, it's a very fine balancing act. And the goal for the perioperative period has to be a zero balance fluid therapy. So let's go briefly into the different types of fluid therapies and the choice of fluids we have. I'm sure you would have heard this before, but I'll just touch on very briefly on why we choose the different types of fluids for each area. So you can broadly categorize them into resuscitation, replacement, or maintenance. A resuscitation is where you give fluids as boluses or small aliquots over a short period of time. And this is generally used in a patient who is in a shock state. A replacement is a bit more gradual process where we are trying to compensate for the fluid losses. And the choice of fluids you could use is crystalloids or colloids. In both these contexts, resuscitation and replacement. For maintenance, it's simply meeting the daily requirements of the body in terms of fluids, electrolytes, and dextrose. And the fluid of choice here is clearly crystalloid. So very briefly on the basic concepts, which we can't avoid when we are talking about fluids. So as you know, a solution is formed by a solute dissolved in a solvent. A concentration is expressed as millimoles per liter. The concept of osmolarity and osmolality comes into play when we're talking about the ability of a fluid to either attract or shift fluid across a semi-permeable membrane. We talk a lot about osmolarity and osmolality. What is the difference? As you can see, osmolarity is the amount of solute per liter of the solvent, and osmolality is per kilogram of the solution. Is it actually important? Practically, not very much. But if you're a physicist, you would say an osmolarity is different from osmolality because osmolarity is temperature sensitive. As you know, with temperature, the volume of the fluid can shrink or expand. However, osmolality is based on the mass of the solution, so it doesn't change. So you can measure the osmolality, or you can calculate the osmolality as mentioned in this formula here. And the difference is what we call as the osmolar gap. So to calculate the plasma osmolality, you simply multiply the sodium by 2, add in glucose and urea expressed in millimoles per liter. Why do we multiply sodium by 2? It's because we're not including chloride and bicarb, because one would assume the amount of sodium would match the sum of chloride and bicarb in the body for electroneutrality. The last important concept is atonicity, which is simply the relation of the given fluid with reference to the plasma and a solution which osmolality is higher than plasma would be a hypertonic solution and lower would be a hypotonic solution. So the fluids we have are crystalloids and colloids, as you know, and crystalloids can be isotonic, hypo or hypertonic, and colloids can be broadly classified as naturally occurring colloids or synthetic colloids, such as dextran, gelafusin, or hydroxyethyl starch. So you can see this table summarizes the composition of various IV fluids. I acknowledge that this is a slide taken from the UK. There may be other fluids which you guys use. You can look at the plasma osmolality, which is between 280 to 300 milliosmoles per liter. The ones at the top are what we call as hypotonic solution. Though if you look at their osmolality, they don't actually differ much from the plasma osmolality, but it's when you give into the body the dextrose, which gets rapidly shifted into the cells, which leaves with a very hypotonic solution. So the water gets distributed more quickly compared to the solutions in the lower half of the table, which are a hypertonic solution, relatively speaking, especially the colloids, which are suspended in normal saline. So they do suffer from the same problem as normal saline, which is the high chloride. So why is high chloride important? As you know, as a chloride ion concentration increases, it narrows the the strong ion difference, and thereby it causes acidosis as per the Stewart's hypothesis. So these are some of the fluids. I must say that I don't have much experience with these fluids, but I don't know if they are still in popular use in India. When I look at these fluids, they can be a bit confusing, but the bottom line is they are all 5% dextrose. With that added other electrolytes onto the solution. Isolate G to me doesn't make any sense because it's neither a replacement fluid nor a maintenance fluid. And isolate P is used in pediatric practice. My preferred choice would probably be isolate M if I was given these, because it would be a good maintenance fluid because of its lower sodium and chloride concentration and its dextrose. It's very similar to the 5% dextrose saline, and add in a bit of potassium, I think it would be a good solution for maintenance. Talk about colloids very briefly. So human albumin is a naturally occurring colloid, obviously derived from human donors. It has the advantage of increasing the oncotic pressure and has some effect on acid base when you give in large amounts. However, they do suffer from some disadvantages, which is the oncotic pressure gets shifted onto the interstitial side, which can worsen the edema when you have a leaky capillary membrane. And the SAFE trial, which compared saline versus albumin, a big randomized control trial, did not show any improvement in outcome. It does have cost implications. However, having said that, I do use it in septic patients occasionally because there is a small trend towards benefit in septic patients. And obviously in liver failure patients, it is quite handy. So the most commonly used colloid is perhaps the gelatin-based fluids, and the one which is most popular is gelafusin, which is a 4% succinylated gelatin. So the advantage is it stays in the circulation for a bit longer, for about 1 to 2 hours. It's cheaper compared to the other colloids, but the disadvantages are it can interfere with clotting, it can cause anaphylactic or anaphylactoid reaction, and it is derived from the bone of sheep and bovines. So technically you can't give it to vegans, and it's contraindicated in kidney transplantation. So the third biggie is the hydroxy ethyl starch, and you can classify them based on the molecular weight and the C2C6 substitution. The advantage is it stays in the circulation for much longer because of their high molecular weight. However, they do have some disadvantages. About 10 years ago, they were quite popular and there was a lot of marketing for these starches. So the year 2012 was particularly a bad year for anyone who invested in starch companies because there were two big studies which were published in the New England Journal of Medicine, the 6S trial and the CHESS trial. And they both showed harm with the starches, especially in septic patients. It's now more or less banned from using. And the second trial, which compared starch versus saline, showed there was higher incidence of nephrotoxicity. It's because of the starches went slightly out of vogue, and the MHRA, which is the regulatory body for the UK, withdrew its license for starches. So you would very hardly see any starches in the cupboard in the operating theatres in the UK. But I acknowledge that it's still in use in other parts of the world. So if you ask the question, are colloids better than crystalloids or crystalloids better than colloids? When you go to big meetings, you'd see the big professors debating hotly which one is better than the other. But the simple answer is you can pick either of the two, it doesn't really matter. Theoretically, colloids have a benefit because they do stay in the circulation for longer than crystalloids. But when you actually look at outcomes, there isn't really any difference as shown in the crystal trial, which compared colloids versus crystalloids. And there have been numerous meta-analyses, including the Cochrane systematic review, which didn't actually show any benefit in terms of outcomes. So we then move on to how to actually administer these fluids in the preoperative, intraoperative, and the post-operative period. Very briefly, the body fluid composition, as you know, 40% of our body weight is, 60% of our body weight is composed of water. And this is further split into 40% in the intracellular space, and the remaining 20% is split as 15% in interstitial and 5% in the plasma. So the daily requirement of water, electrolytes, and glucose, a simple way of remembering is number 1. So 1 ml per kilogram per hour will be your hourly requirement, and 1 millimole per kg per day of sodium chloride and potassium, and 1 gram per kilogram body weight of glucose will be your daily requirement for patients. It is important to know what is the electrolyte composition of different body fluids, especially when we are dealing with sick patients coming for laparotomies. As you can see from this table, the upper half are upper GI fluids, which are rich in chloride, slightly lower in bicarbonate, except for pancreatic juice. So when a patient is vomiting predominantly, leading on to dehydration, you would see a hypochloremic state, which causes an increase in the strong ion difference, and thereby causing alkalosis. However, if you have a diarrhea, which causes dehydration, then you lose predominantly bicarbonate rather than chloride, which results in metabolic acidosis. So in an elective setting, preoperative fluid therapy is very simple. All you have to do is just follow these 3 goals, which is keep the fasting period as little as possible, and allow patients to drink water up to 2 hours before surgery. And carbohydrate loading has been shown to improve outcomes in bowel cancer elective surgery. And for low GI surgery, preferably avoid bowel preparation, as it can cause dehydration. In an emergency setting, however, it's a little bit more complex. So you have to take several factors into consideration. Importantly, the acute physiological status of the patient and the chronic health, which will determine how quickly you can give fluids to the patient. Obviously, urgency of the surgery matters, and so resuscitation may have to happen in parallel with surgery. When you're talking about assessment of the patient, so we need to assess the level of dehydration. How we do that? So we go on to our clinical observations, such as heart rate, blood pressure, capillary refill, respiratory rate. The JVP can be useful, the consciousness state of the patient, and urine output. Now, urine output is contentious. I would say in a preoperative setting, urine output is quite useful because most likely the patients are dehydrated in a preoperative setting. So I do look at urine output in this context. You can assess the patient's fluid responsiveness by performing a simple passive leg raise test, or you can look for orthostatic hypotension. And you're going to look for the blood results. And the most important one in this context would be a blood gas analysis, and to look for a base deficit and the lactate levels, which may indicate hypoperfusion. So the first question is the patient in shock? If the patient is in shock, as in the patient has got significant hypotension or raised lactate, very poor capillary refill and motile, then you would administer boluses of fluids, usually administered as 250 to 500 ml of crystalloid or colloid crystalloid as a balanced salt solution. And you keep giving these boluses, looking for an improvement in the shock state. And you reassess. After you've given about 2 liters, it's not an endpoint, but it's worth considering the role of vasopressors or inotropes. When the patient is not in shock, you have a bit more time and to estimate the actual level of fluid loss. So the different ways of doing it. So a simple way, or probably the most accurate way, would be to just measure the patient's weight. So if you know the patient's accurate preoperative weight before the disease pathology, and then measure the patient's weight after, the weight lost in that short span of time would simply correlate with the amount of water lost, and you can replace that. But it is not practical, it's a bit cumbersome. So the next option, which we are taught historically, is to use the formulas, which is you multiply the hourly maintenance requirement of the patient with the hours of fasting, and you add in the patient's measured fluid losses, and you give half of this amount in the first hour and the remaining half in the next 2 hours that follows after that. But we know that by doing this, we can actually overestimate the volume requirement, and we can actually give too much fluids to the patient. So perhaps a better strategy would be an individualized fluid therapy based on the clinical indicators, including your physiological observations, and take into context the losses from the various sites, and give fluids as boluses to the patient and reassess. You can give 500 ml bolus of crystalloid and constantly reassess. That would be a better strategy. And the replacement fluid is usually a balanced salt solution, or you can use colloid, but be wary of hyperchloremia if you're using colloid. And obviously that would take into consideration the electrolyte derangement and replace them accordingly. So the intraoperative fluid therapy is, once again, a conventional strategy is the hourly maintenance plus replacement losses, and what we call as a third space loss, which is simply the shift of fluid from a functioning compartment to a non-functioning compartment. And we used to get told that it can be up to 6 mL per kg per hour for major surgeries. If you work it out, this actually results in quite a lot of fluids given in a very short span of time, and it leads to excess fluid administration. So alternate strategy is you can have 2 cannulas and use 1 cannula for the maintenance fluid that you normally give for the patient, and use the second cannula to give fluid boluses, as in what we call as a goal-directed fluid therapy. The maintenance fluid requirement is slightly higher during the intraoperative period to account for the insensible fluid losses. And another important shift in the paradigm is the ratio of blood loss to the amount of crystalloid or colloid that you would give. We used to give 1 to 3, but we don't do that anymore. 1 to 1.5 is enough for crystalloids, and 1 to 1 for colloid. So we're all familiar with the Frank-Starling curve. And so the goal is to reach the steeper part, the plateau part of the curve, and not to be on the sharp rising steeper part of the curve. By doing that, what you're doing is ensuring the LV is optimally filled to improve the cardiac output. So intraoperative goal-directed fluid therapy is very topical, very popular. And so what does it mean? It simply means you're using a protocolized hemodynamic optimization and using an end goal. Quite often, this end goal is attributed to using these fancy monitors, which are at the bottom of the screen. It doesn't have to be. You just set a goal, whatever you decide, based on a combination of physiological parameters, and then give fluids in a targeted way. That would still be a goal-directed fluid therapy. They are classified broadly into static measures and dynamic measures. Static measure is kind of a misnomer because all these variables are actually continuous variables. But what we mean by static measure is we take these values in isolation rather than taking them in conjunction with the patient's respiration. So a dynamic measure is where you measure these variables, how they change with each breath cycle. And the most commonly used ones are pulse pressure variation and stroke volume variation, which are the most validated variables. So all these monitors at the bottom, the cardiac output monitors, the pulse contour analysis monitors, and the esophageal Doppler monitors, and we have newer non-invasive monitors. You can use any of them. The invasive ones are obviously more accurate than the non-invasive ones. Esophageal Doppler, when you use them and when you get a good trace, it is fantastic. And I think it is more accurate than your pressure-guided monitors because you can actually measure flow. However, there are a lot of patients where it's a bit fiddly, you don't get the optimal position. So we tend to use pressure-guided monitors more than the esophageal Doppler. So we're all familiar with the swing in the arterial line. And why does a swing happen in a hypovolemic patient? When you give a positive pressure breath, you're squeezing the blood from the lungs into the LV. So it gives a small fluid bolus, which causes an increase in the stroke volume. And when you let go, the opposite happens. So you can quantify this by the pulse pressure variation or the stroke volume variation with each breath. If the SVV or the PPV is greater than 10%, it indicates the patients may be fluid responsive. It's important, I say, the patient is fluid responsive and not hypovolemic, because even in a normal patient, you can cause this response. You can produce a pulse pressure variation, stroke volume variation. It's only useful when you're trying to ask a specific question: do I need to give fluids to this patient? And there are lots of caveats associated with this. It's not validated in spontaneously breathing patients. It's not useful in patients with arrhythmia. It's not useful in people with open chest, and when you're using low tidal volumes, or people with high intra-abdominal pressures or high PEEP. So that's all the physiology. So is there any evidence actually goal-directed fluid therapy improves outcome? So the answer is yes. So the big trial, which is the optimized trial, which looked at goal-directed fluid therapy in high-risk surgical patients who are having gastrointestinal surgery, showed there was an improvement in outcome in terms of 30-day mortality and morbidity, major post-operative complications in the interventional group. However, it did not reach statistical significance. So the authors persevered, and they did a meta-analysis of about 38 trials, and then they proved, including this trial's data, and they proved that actually goal-directed fluid therapy was associated with improved outcomes compared to a liberal fluid strategy. However, goal-directed fluid therapy has not been tested against a restrictive fluid strategy. There have been many trials published in that, and a Cochrane systematic review showed that it was no better than a restrictive fluid strategy. So my take on goal-directed fluid therapy, I think it is definitely useful when you're doing high-risk major surgical cases rather than being guided by CVP or blood pressure. You have a bit more accurate indices such as the pulse pressure variation, stroke volume variation, and you can guide them to give fluids accordingly. And but however, it's not really useful for minor to moderate surgeries. I think the cost doesn't justify their use. So going on to post-operative fluid therapy, very briefly, the important physiological principle applies to this is the renin-angiotensin-aldosterone system. Why is it important? During surgery, as you know, the RAS system gets activated, releasing angiotensin II, and this causes a whole raft of effects on the body. Most importantly, the fluid retention from the kidneys, hypernatremia due to hyperaldosteronism. So how do we give fluids in the post-operative period? So you give a maintenance of 1 to 1.5 mL per kilogram per hour. You compensate for the losses, the ongoing losses, and more importantly, you monitor the clinical parameters as you normally do. Goal-directed fluid therapy is debatable in this context, so I wouldn't personally advocate that at this stage. And once again, this is the period where we really have to cut back on the fluids and aim for that zero fluid balance and proactively stop IV fluids and restart oral intake as soon as possible. So can we get it right? Yes, if we treat IV fluids as drugs, we wouldn't use any drug indiscriminately. We would have to establish what is the indication, choose the right fluid, calculate the dose, and administer with an end goal and stop when it's not required. So if we apply these principles, then I think and use IV fluids judiciously, we can get it right. So in summary, fluid therapy includes water and electrolyte therapy. A zero fluid balance should be the aim of perioperative fluid therapy. The choice of fluids you can determine based on the indication, whether it's resuscitation, replacement, or maintenance. In the preoperative period, estimate the loss, replace, and give us fluid boluses, and rather than using any formulae to pre-calculate. Intraoperative, the same principles, goal-directed fluid therapy, if available, is useful. And post-operative period, watch out for a fluid creep, and more importantly, hyperchloremia is a big problem. So be cautious with that. And finally, stop IV fluids when it's not necessary and encourage patients to drink as soon as possible. Thank you very much.
Thank you very much.
Thanks a lot. I will just go to the chat questions which have been put up, Dr. Selva. It was a very nice presentation. Let me see what people have asked you, and I will just post those questions to you. The first question is, can we use dextrose containing fluid for maintenance after neuroaxial block?
So it depends. I do not see, not immediately after a neuroaxial block as a replacement fluid. So if the patient is hypotensive, for example, and you want to give fluids, then clearly that's not a good option. But once the neuroaxial blockade has worn off and the patient's blood pressure is not an issue, then I don't see a problem being used as a maintenance fluid. So we all need glucose for the post-operative period. Even in diabetics, we know they need glucose. Yes, it depends on the indication, not for replacement, but for routine maintenance, it's not a problem.
In this juncture, I'd like to ask one question regarding glucose solution in pediatric patients, especially when they are starving for 3 hours or 4 hours.
So I must confess, I'm not a pediatric anesthetist, so that's not my area of expertise. But perhaps Professor Kundra can be able to share his wisdom on that.
Even in pediatrics, I think it's a better mix, depending upon the age, of course, and it is a better mix to use ringal lactate in combination with 5% dextrose. I think using alone 5% dextrose is now almost gone. We hardly use it.
Yes, invariably the premature children or even children between the age group of 0 to 1 year, when they starve for about 3 hours, sometimes they go for hypoglycemia because the blood sugar level drops less than 40. So we have to do a periodic glucose test and also infuse fluid, as Pankaj Kundra says, in a graded manner. Otherwise, typical stopping of glucose in many of the pediatric patients lead on to hypoglycemia and all other post-operative complications.
Okay, Selva, there's another question. This is regarding use of ringal lactate. So the question is whether ringal lactate is a good choice in patients with acidosis, and won't ringal lactate contribute or attribute to acidosis?
Yeah, very good question. Obviously, ringal lactate has 30 millimoles of lactate in it, and the expectation is the lactate would get converted to bicarb in the body. So the answer is, if you have a functioning liver, and if the acidosis is simply due to hypoperfusion state, then you can use ringal lactate. It's not a problem. I use it quite commonly, because what is the alternative is you need to ask yourself. So giving normal saline is clearly not a good thing because of its hyperchloremia. Plasmolite is a slightly better option if you have, which is called acetate instead of lactate. But I wouldn't deter from using ringal lactates if you have a patient who is in shock. It's quite common to see septic patients with high lactates, and the high lactate is due to type 1 lactic acidosis rather than type 2. In those patients, clearly it's not a problem. But if you have a patient with liver failure, or if the liver is shocked, then you'd have to be a bit more cautious. You'd give ringal lactates and you need to monitor, or you'd have to use a colloid such as gelfusin or albumin.
Yeah, I totally agree with you. As long as the liver functions are preserved, lactate is safe, because it primarily undergoes oxidation and gluconeogenesis, and it finally gets converted to bicarb. So it's not a bad idea that even if you have acidosis because of hyperperfusion, that ringal lactate would probably give you a good buffer as well. Okay, the next question which has been posted here is, just a minute. How do you do carbohydrate loading? This is with respect to ERAS, I guess. So
yeah. So I mean, in the UK, basically a couple of hours before surgery, the patients get admitted on the day of surgery. They don't come in the previous day. So as soon as they come to the day case unit, the pre-op nurse will give them a sachet which contains carbohydrate. It's a pre-made solution. It is a clear fluid, so it's not a particulate solution, and it's just given a couple of hours before surgery. That's how we do it in the UK.
Okay, there's a very interesting question and probably very dear to my heart as well. What is the role of endothelial glycocalyx when you talk about fluid therapy?
I think endothelial glycocalyx is a I wouldn't say it's a controversial, it's a debatable one, and I wouldn't say all physiologists have signed up to it personally. I'm not one of those on the the glycocalyx side of the argument. Prof. Kundra, you can share your insight into that. You're probably more well-versed than me on this.
No, I can talk about it for 45 minutes, but I don't want to land up into that kind of a topic right now. But yes, glycocalyx has a role, and it basically, whenever there is inflammation or fluid overload, and specifically when you talk about saline, and if the glycocalyx layer is disrupted, then you have a lot of interstitial edema and the fluid going into the interstitial compartment as such. But interestingly would be what I would like to hear from you, Selva, is when do you consider albumin as a choice of as a colloid to be given in patients perioperatively?
So perioperatively, I do not use it intraoperatively for a start. As you know, there are two options for albumin. It comes in 5% has solutions or 20% has solutions. And the 5% has is essentially suspended in normal saline. It comes in 250 ml vials, and the 20% has is a small volume, which is a salt poor albumin. It doesn't matter which one we use. I use it in patients, in emergency post-op surgical patients, if I think I need to use colloid, particularly if they are septic, as in if they've had a bowel perforation and then in need of inotropes. If I need to give fluids as a fluid bolus, I do use HAS in that context, but I do not use in the intraoperative period because simply there is no evidence to substantiate their use and the cost implications of that.
Fine. Another question, what is the action of ADH, that is antidiuretic hormone, during anesthesia and after anesthesia?
So yes, ADH is part of the RAS response. So as you know, once the angiotensin 2 is activated, it activates the release of ADH from the pituitary. So the action is on obviously the collecting tubules. It retains more water. Why is this important is because have you ever heard of SI-ADH, a syndrome of inappropriate ADH secretions? It's quite common, especially in the elderly after a big surgery. And so the way to watch out for that is to do paired osmolalities, do a serum and urine osmolality, and you would see an increase in urine osmolality and a drop in serum osmolality. When you see that, that essentially means the patient can be fluid overloaded, and you'd have to back off on the fluids. And the temptation is to use normal saline in this context, but the answer is actually not, because it will just make it worse. So it's mainly fluid, holding back on the fluids and let the body clear the excess water. If you look at physiologically speaking, we humans are very good at when we're able to cope with hypovolemic and hyponatremic state, as in, the early humans didn't get free access to salt and water like we do in the modern days. So the kidneys are very good at concentrating water and sodium, but they're not very good at clearing water and sodium, which is a problem, which is what we see in the post-operative period. Yes, syndrome of inappropriate ADH secretion is an issue, and particularly major surgery in elderly people is a problem.
Okay, I think the last question I will put across, and then we will switch on to the next speaker. The question is, like in ARDS, there is tendency to keep patient dry. We do that in COVID lung too. Restrictive fluid inevitably leads to increase in blood urea nitrogen. What is your upper limit to accept increases in urea and creatinine before you abandon restriction in fluids in ARDS?
So in ARDS patients, as we know, the FACT trial showed that restrictive fluid therapy is actually showed to improve outcome. And also there is a lot of evidence in the critical care population that the cumulative fluid balance, if it's positive, leads to increased length of stay and worsening outcomes. If you ask me specifically in ARDS patients, what we do, I mean, this is not based on any big trial evidence. We do run the patients dry, and how much urea and creatinine we accept. So a rise in urea is not a major issue because that just implies a prerenal state or slight hypoperfusion of the kidneys. And it's a balance, you know, it's the better of the two devils, which is worse. The lung is a major problem or the kidney is a major problem. But when you start to see a rise in creatinine, that is a concern. At that point, you'd have to stop actively diuresing the patients. And sometimes we do accept the fact that the kidneys would inevitably fail in severe ARDS patients when you're ventilating them on 100% oxygen, prone them, fully paralyzed. And in this context, rather than just keep waiting and waiting for adding more strain to the kidneys, we just put them on reducing therapy and take over the role of kidneys. Then you don't need to worry about the fluid balance side of things. So there isn't any specific number as such we would allow the urea and creatinine to rise, but an isolated rise in urea is less of a problem than a combined rise in urea and creatinine.
Thank you very much, Dr. Selva.
There
are a number of other questions.
Before concluding, only one question, that is a practical one. When will you consider vasopressors when the fluid response is poor?
Okay, so if you look at the goal-directed fluid therapy regimes, the first step will be to give fluid. So if you have a dynamic variable such as pulse pressure variation or stroke volume variation, the first goal is to get the SVV and PPV less than 10%. So once you've reached that target, then if the patient's blood pressure is still low, then it means that it's due to low peripheral vascular resistance or due to a lower cardiac output. So there are three different things. One is the preload, the contractility, and the peripheral vascular resistance. So once you've optimized the fluid balance, then you can, the next step would be to add in vasopressors, which is, you can use your choice, either metronidazole, or in a septic patient, you may want to use NORAD. So fill the patient first and then consider using vasopressors or inotropes.
Finally, a practical question, that is, you cannot always plan for a goal-directed therapy for all surgeries because some of the surgeries are minor one. Then when will you decide on restrictive fluid therapy or liberal fluid therapy or goal-directed therapy? How will you classify the patients?
So the goal-directed fluid therapy is only implicated for major surgeries. I should have probably made that clear. It's not, there's no point in using goal-directed fluid therapy for a hernia operation or it has been shown to be useful in major orthopedic surgeries, but if you're doing simple operations or moderate surgeries, there's absolutely no use in goal-directed fluid therapy. You just switch to your usual physiological variables that you would normally use. Sorry, what was the second part of the question? I missed that.
How will you choose the patients for restrictive fluid therapy? Because nowadays surgeons are very much interested in enhanced recovery and things like that. They want to reduce the fluid and they want to give more fluid, things like that.
Yeah. So once again, if you're talking about an elective setting, if by keeping the preoperative fasting status as little as possible means that the patient is adequately optimized. So the intraoperative fluids that you're going to use is mainly to compensate for the intraoperative fluid losses. You do not need to catch up for the 2 or 3 hours of starving period that the patient has. The body can perfectly tolerate that. And during the intraoperative period, we are much more cautious with fluids these days. So as I said, this is how I personally do it. I have 2 cannulae and run one just simply for maintenance, what I think will be the maintenance requirement, and then use the second cannula with either colloid or a balanced salt solution to just give boluses as required when I see a drop in the blood pressure, which is not, and the patient is needing frequent doses of vasopressors, then clearly, and giving fluids, you can't go wrong. If you look at the 4 types of shocks, fluid is the answer for 3 types of shocks, except for cardiogenic shock. And cardiogenic shock is rare unless you've not screened the patient well for heart failure. Fluids, you can't go wrong with fluids initially, but what I would advise is give fluids cautiously, small allocates, small boluses, and look for a response.
Thank you, sir.
I have a question and a comment, sir.
Thank you.
It's a very good talk, Dr. Selva. You said about rule of 1, that is 1 ml per kg per hour fluid, 1 millimoles per kg per day of electrolytes, and 1 gram per kg of glucose. That is a really good one, and everybody should remember about that. And regarding the fluid strategy, zero balance strategy is a current recommendation. Either restrictive or zero balance strategy is the current recommendation. And type of fluid is balanced salt solution, either plasma light or that type of solution is preferred one. And my question about monitoring, because the static measures like heart rate, blood pressure, CVP, SVOT is not reliable in the perioperative setting. Current recommendation is to go for the dynamic variables like stroke volume variation, pulse pressure variation, all those things. Do we practically follow in all those dynamic variables in majority of our cases in the perioperative period?
Yeah, so once again, I only ever get these monitors if I'm doing major surgery, as in bowel resections and things like that. It's not really worth the time to use it for small or moderate surgery. There's absolutely no evidence to say they are better than your professional guess. So the dynamic variables, how do we? Sorry, so what was your question specifically again, sir, Dr. Kannan?
No. The monitoring the fluid therapy in the perioperative period, the static measures are not reliable as per the current literature. So we should go for the dynamic variables like stroke volume variation, pulse pressure variation, and IVC diameter and TE, all those things. Does it practically sound to go it for all the cases in the perioperative period, or you have to choose for major cases and only indicated cases?
I would choose it only for major cases or sick patients, the emergency laparotomy patients who are septic. It's really useful. One thing I didn't touch on in this topic is the role of echocardiography, which is my personal favorite, I would say. It is quite tricky to do it intraoperatively, which is why I didn't touch on, but it's invaluable in the post-operative setting. So it can give you the answer straight away to know what type of shock the patient is in. So if you pop an echo probe on and you see the LV is empty and the ventricles are kissing, so you know the answer, you need to give fluids to these patients. IVC diameter yes, there are indices such as distensibility index or collapsibility index, depending on whether the patient is mechanically breathing or spontaneously breathing. I would take it with a bit of pinch of salt, yes, if you have these monitors like stroke volume variation, pulse pressure variation, they are useful for the intraoperative setting, not so useful in the post-operative setting because they're not validated for spontaneously breathing patients, where echocardiography is probably more useful in those settings. I do use them in ICU when these, so if you have a sick laparotomy, they would automatically come to ICU. So I use an echo to look at their LV status and use that to guide my fluid therapy.
Thank you, sir. Thank you, sir.
Thank you, sir. Before conclude of this topic, I would rather tell that is the institutional guidelines for each institution should have a separate guidelines for the fluid management. Of course, there are consultants and they will be planning guidelines as per the current day. The availability, depending upon the availability of the monitor and the skilled persons to deal with it, because everybody cannot have a goal-directed therapy in every situation. So the institution, though it is a medical college or a small private institution with 40 beds, they should have their own guidelines that should be known to everyone in this hospital. There should not be a variable guidelines which mislead all the paramedical staffs and lead into problems in fluid therapy, which is detrimental to the patient.
May I just add a few lines before we
conclude? Sure.
Dr. Selva and respected Professor Kannan, as far as the experience goes for intraoperative fluid management, I think even institutional guidelines don't work. It is individual patient guidelines. The patient tells you how much fluid has to be given.
That's true. That's
So
true.
what normally has to be done is not a single parameter is generally a good indicator. I would rather have a combination of few parameters to judge if the patient is fluid responsive or not. I think that's what we failed to touch upon, because goal-directed therapy is fine, but we need to find out whether the patient is going to be fluid responsive or he is not fluid responsive. That's the distinction we'll have to make immediately when we talk about fluid therapy. The second aspect is what parameters you will see. Given to me, I would look at all the hemodynamic variables, the pulse oximeter, the EtCO2. If I have a direct arterial line, at least see the swings which are happening in the baseline with each inspiratory cycle, or inspiratory and expiratory cycle. The urine output, the peripheries, what is the temperature, how the peripheries are, whether the oximeter is picking up the signal well, or do you need to amplify the oximeter signal to get it properly, to get a proper waveform. The EtCO2, how it is behaving. Is it coming down? It is stationary? What was the trend of EtCO2? And perhaps added to that, the other parameters which you would normally consider. Maybe an ABG if I am in doubt, to see if there is lactate which is rising, if there is a base deficit. What's the hemoglobin of the patient? So I think all these parameters, when you take into account together, that gives you a better sense to know what and how much fluid should be given to the patient. That's all I can suggest in the end.
Thank you, sir.
Thank you
I
very
agree with
much.
you, Prof. Kundra. Yes, so I think it's individualized fluid therapy based on taking into account all those the parameters, as you said. Yes, thank you.
Thank you very much. Thank you very much, Dr. Selva, for sparing such time, and thank you for bearing with us with the flurry of questions which have come to you. It was really nice to interact with you. Thanks a lot.
Thank you, sir. It's my pleasure.
And,
thank you.
With the permission of my co-chairman, respected Dr. Kannan, I hand over the proceedings to Dr. Kumar for the next lecture.
Thank you very much.
Yes, sir. I think we'll move on to the next talk. It is a very good talk by Dr. Selva. Thanks for sparing your valuable time, especially in the early morning, 5:30, you get up and you are sparing your valuable time with us. Thank you very much. I think I'll hand over the session to Dr. Kannan sir to proceed for the second lecture.
Yes. The second lecture, as we have planned, it is the COVID-19 patients coming for cesarean section. Incidentally, she had a rheumatic heart disease as well as pneumonia. And it is to be presented by Nishal Perumal. Nishal Perumal is a graduate from Annamalai University. He did his MD and for the past 15 years, he is practicing anesthesia in Phenylephrine. He is an assistant professor in Tharaikona Medical College. Later, he is a senior consultant in Jayasekharan Trust Hospital. And he is, to his credit, he has got 2 papers published. And invariably, in all the state conference and national conference, he will be presenting a lecture. In fact, if you don't present a lecture, you will put a volley of questions to the senior persons and get the right answer from them. And for the past 15 years, he has been very much interested in teaching dependent students. And I personally observed that. And he has, through him, he has produced nearly 15 to 16 dependent students passing in the first attempt. So these are all his credits. And coming to the subject, that is COVID-19 and for cesarean, pregnancy itself is a nightmare to the families nowadays. The anxiety level running high. On the top of it, there is mitral stenosis and the newer novel COVID-19. We yet to know the full picture of COVID-19, to understand the COVID-19. So such patients are comes for a pregnancy. The nightmare is dealt by Vishal. Let him hear his nightmare, how he managed successfully this patient. Over to Vishal.
Thank you, Kannan sir.
Yes, Nishal, you can proceed.
Yes, 1 second, sir. I'll just share. I bring greetings from ISA Kanyakumari first, sir.
Vishal, please put it in slideshow, please.
Yeah, I've done it, sir. Are you seeing, not seeing?
Yeah, now better, now better. Yeah, okay, fine.
Okay. I first bring greetings from ISA Kanyakumari, sir. Thanks for State ISA to give us an opportunity to present this time. And I'm really happy to see you all. Every conference we meet, and I see all my friends there now after a long time. Only by the ISA Tamil Nadu, I'm able to see you all at least weekly once nowadays through the webinar. And this is the hospital I work. I bring greetings from Jaysharan Hospital. Now I'm going into the topic where I'm presenting a case of an RST, known RST patient's complicated pregnancy in term with Corax 5 pneumonia. To start with, when we saw this patient for the first time, we saw her in the cardiac care unit. She was 34-year-old, G4P1L1A2. She is an unbooked case for our hospital, and she's 36 weeks of gestation, presenting with the complaints of breathlessness for past 4 days. She was being evaluated outside prior. Her echo report showed moderate to severe mitral valve stenosis. Valve size was 1 centimeter square and with mild pulmonary hypertension. We were called in for the consultation in the cardiac ICU, where we saw her. She was conscious, oriented, but she was tachypneic and tachycardia was also present. She was not able to lie down. She was sitting, and vitals were heart rate was 130, BP was 110/60, and respiratory rate was 36, and SpO2 was only 89% with a ventimass of 15 liters of O2. So, and she had a diastolic murmur. We auscultated her. She had bilateral air entry was equal, but there were basal crepitations. So we could not make it whether this is this is a period where COVID cases were rampant, and we did not send because just 1 hour prior she has received in our hospital. So we advised we at least put her in an NAV with a 60% O2 with pressure support of 16 centimeters of water with PEEP, and we'll send in for a COVID to see what she's going to require. We also started her on heparin 5000 units sub-Q TDS, and we send in a COVID swab test, send in pro BNP, serum ferritin, D-dimer, IL-6, and also we added on augmentin 1.2 grams IV 8 hourly, and we gave Lasix 40 milligram IV stat, and we started an Lasix infusion with 40 milligram and 40 ml normal saline at 2 ml per hour, meaning that 2 milligram Lasix every hour she was getting as an infusion. And she was already on Prolomet XL 25 milligram OD, digoxin, Pentix, and Amifru. She was already on. On the BiPAP, she was maintaining the saturation of 95% with 60% O2, and we were okay with that. But in the later in the night, as the evening progresses to night, her saturation slowly dropped to 88%, from 95 to 88%. And so FaO2 we slowly increased from 0.6 to 0.7, then 0.8. Then at last we had to go with 100% oxygen to maintain saturation of 95%. For normal COVID patient, we are accepting 90% saturation, but because of pregnancy and fetal oxygenation, we are worried about, so we were aiming at 95% saturation. On the day 2 morning, we were again called And we saw the patient in the cardiac ICU, where she was maintaining saturation of 95% with 100% O2 on a BiPAP with 16 to 80 centimeters of water and a PEEP of 8 to 10 PEEP. She was again conscious, oriented. The tachypnea was there, but reduced respirators from 35 to 40. It has come down to 30. But tachycardia, it has reduced from 130 to 110. Kind of a better signs, I thought. She's getting slightly better. But at the time the bomb came as she was COVID positive. The test result came as positive. And in view of her fetal heart rate variation and the patient condition, the obstetrician, after talking to the seniors of the hospital, surgeons, everybody, she posted the case for emergency LSCs and a GA. And we also discussed with the cardiologist, pediatrician, obstetrician about the high risk concern, on-table mortality concern we got, and post-op ventilation concern we got. Thankfully, the whole family was supporting us, saying everything is okay. Please take care of the baby and her. That's what they said. But we really talked about on-table mortality with them. Mother started crying and all those things happened, but we had no other choice. And then we shifted the patient to the COVID ward. In the COVID theater, the patient came with, when we were transporting the patient, we removed the BiPAP and we kept her on non-rebreathing ventimask in the sitting posture on the trolley. And we slowly shifted with all anesthesia PGs, dependent PGs. We have wonderful dependent PGs, hardworking people. So they were all coming along. I walked along with the patient. We slowly shifted to the theater. When we were reaching the theater, saturation was only 86%. So we prepared ourselves. The patient was shifted into the theater. Two of our PGs were ready with the full PPE to receive the patient in the COVID theater. And we shifted them with her, and we all changed to full PPE. And we also explained to the patient about all the procedures we are going to do to her. For that, she said, okay, please proceed. So in the table, like one of my friend who was holding anesthesia, holding the mask with the pain circuit with 15 liters of O2. And myself, I cannulated the right radial artery. Then we tried to put in a triple lumen cell catheter placed through the right subclavian vein under sterile conditions, because jugular, because they were holding the mask and she was struggling kind of a sitting posture. So I could not go in for right jugular. We went with right subclavian vein. On the through the central line, we started to monitor the CVP, which showed starting was 20 centimeters of water pressure. It showed. We started Norepinephrine 8 milligram and 50 ml normal saline infusion was started at 5 ml per hour, around 10 mics per kg calculation comes around. Then the last 6 infusion was again continued. And we started one more line, RL at 50 ml per hour was also started. The struggle we had was to make her lie down before intubating. She was cooperative to the extent she listens to all our shift your head to the side and all those things. She said she was cooperating, but lying down she was really not cooperative as much. So we first gave some 50 fentanyl, then slowly we started giving etomidate. Patient was kind of sitting with the mask hold on to her face by my friend. Then half the dose of the etomidate, around 5 ml given, she slowly kind of sedated, she lie down. Then remaining fentanyl 50 we gave, and total of etomidate 10 ml we gave, then scoline 2 milligram per kg IV we gave, then fentanyl 100 we gave. And we informed the pediatrician at that time that we are giving some amount of, good amount of opioid, so to keep the naloxone ready to resuscitate the baby. We asked him to be ready. Dr. Gopal, our pediatrician, he was ready with the intubating trays and everything. He was ready there. And after induction, even on the brain circuit with 100% oxygen, with fully holding with tight pressures, I was ventilating, he was holding, and patient started desaturating to 80%. So we immediately put in a tube, I cuffed endotracheal tube of 7.5 size with the help of bougie, and we started ventilating with the brain circuit. But saturation was not improving, so we connected to our ventilator and started using some PEEP and pressures, and but still the saturation was with 100% oxygen, the saturation was only 82%. Uh, we were about to start surgery, but we started with air and oxygen 80% FaO2, and to abolish the awareness because we are not able to use nitrous oxide or sevoflurane or isoflurane, but to abolish the intra consciousness, we gave 50 milligram ketamine. I know the patient was having RST, the heart rate is high. But during this period, my arterial, we have already sent in an ABG also. My arterial line is started showing there is a hypotension. The BP slowly started falling from 110/70 to 90/60, then 80/60, 80/40 slowly. So I thought ketamine will help me all the way. The patient was already on NORAD infusion 5 ml per hour, and 50 ketamine was given. And after 3 to 5 minutes, again 50 milligram ketamine was repeated. Proceeded with fentanyl and vecronium. Uh, so saturation started to build to 82. I mean, it was showing from rising trend like 78 to 80 to 82. Then we asked the surgeon, obstetrician, please proceed with the surgery. She was looking at our monitors and say, is it okay to start now? I said, we have no other choice. Please go ahead, and we'll take the baby out as early as possible. And surgery was started. After 1 to 2 minutes of surgery, she said, color is really black. Could you do something? Then this time only I realized my seniors like Kannan sir, our seniors Yanamani sir and Jeshir and Rajendran sir, they all used to tell us that once upon a time they used to do surgeries with ether and all those things, and surgeons just suddenly call, hey, blood is turning black, do something, and they immediately ventilate with the ampu pack. Those kind of stories I've heard, but on table saying color of, I mean, arrested patients, we can see black. This is really black because I think she was under hypoxia for a long time, even though the saturation is 80%. The color of the blood was really scary at the time. But surgeon, we explained our situation to the obstetrician, and she was kind of okay. She's a bold gynecologist, obstetrician, Dr. Maya. She proceeded with it. At that time, vital signs were pulse rate was 120 per minute, saturation, I mean, BP was 80/40, saturation was 80 with 100% O2 on ventilator with PEEP and with tidal volume of 450 to 500. At the meantime, we got the ABG results after, as soon as we put the arterial, we send the ABG. So ABG came as pH 6.8 at combined respiratory and metabolic acidosis. So we gave slowly again 5 ampules of 7.5% sodium bicarbonate. We gave slow infusion, was given on peripheral line. We gave slow infusion. Introp, after shifting to all this, after 10 to 15 minutes, slowly a saturation started improving from 80 to 88. Then PEEP when PEEP was increased to 8, then 10, 12, she maintained a saturation of 83%. At this time, the baby was delivered with normal upgut, right at birth. The pediatrician was very happy. He said, come on, man, good. And he immediately shifted the baby to the special ICU. And after the delivery, the saturation improved from 93 to 96%. And after the bicarb, sodium bicarb, injection. The blood pressure also improved from 130, improved from 90/60 to 130/90. Norepinephrine infusion was going at 5 ml per hour. We reduced to 2 ml per hour. And at this point, we are very sure that we are going to ventilate our post-op of 100%. And we gave morphine 5 milligram, then vecronium we gave paralyzed. After this point of thing, there was no dramatics. Anything was there. Saturation is 96% with 100% oxygen, completely paralyzed and ventilated. But again, Mike, at this point, my worry was again we have to shift the patient to our ICU where we don't have. We shifted with a transport vein circuit, which we cannot provide PEEP as such, but we just close the valve a little bit and try to give PEEP and ventilator while shifting the patient to the ICU. She was shifted to post-operative care unit with vein circuit with 100% oxygen. But valve was not fully open. I mean, partially closed during ventilation, so that kind of a pass while ventilating with the hands also kind of slow release of the back. Somehow we reached the ICU with saturation around 90-92%. Over there, we have started antiviral remdesivir 100 milligram OD. We gave introp only. We gave Dexa 8 milligram, but over there we started F-colon 50 milligram 6th hourly and antibiotic piperacillin tazobactam 4.5 gram IV 8th hourly was started. She was paralyzed and sedated and in the ICU, and she was on NORAD infusion 1 to 2 ml per hour, Lasix infusion again 1440 1 to 2 ml per hour. She was getting heparin 5000 units up to TDS. Because she was on metoprolol, long-acting metoprolol pre-operatively, we continued metoprolol 5 milligram dilute to 100 ml normal saline 8th hourly. Then sedation, we gave it dexmedetomidine 100 mics in 50 ml at 3 ml per hour. Vecronium, she was paralyzed with vecronium 1 milligram hourly and SOS. Antibiotics, antivirals, digoxin, steroids, everything was continued. IV fluid, we did not want to give much IV fluid, but we were giving RL 1 liter. In RL 1 liter bag, we added 50% dextrose 20 ml, and we were giving the mixture at 50 ml per hour. Then for pain, paracetamol 500 milligram IV 6th hourly started, and we had a special advice like fentanyl 20 mics SOS if heart rate goes above 90 per minute. And on the ventilator setting, we put her on a volume control mode with the SIME and with the pressure support ventilation. The tidal volume we kept at 300 first, then we increased to 400. Then respiratory rate 20, we started 22, then to 24. PEEP, we kept a 6-8. We even went to 12 centimeters of water, but when we went to 12 centimeters of water, the BP started falling. Then we thought, okay, 8, we'll hold on to 8 for the first 1-2 hours and see later. Pressure support we kept at 14 to 16 centimeters of water. E ratio we just kept 1:2 because ABG at that time was PCO2 was also high, so we kept the E ratio 1:2. And after over a period of time, we could titrate the FiO2 from 0.9 to 0.6, maintaining a saturation of around 94. We were happy there. At that point, our ABG showed pH as nearly normalized, 7.3, and such PO2 is 80 and PCO2 is 46, and by kind of she's kind of recovering look she gave us. On the post-op second day, she remained very stable. Again, we paralyzed. We did not want to take trouble, so we just paralyzed and sedated her. Heart rate was 110. BP was 110/60. Saturation was 95 with FiO2 of 0.6. Now we want to know about her lung status, so we shifted her with a vein circuit with 100% O2 for a CT thorax. Where CT thorax, it showed multiple areas of patchy consolidation with a score of Corad 5, Corad 4 plus PCR positive, so we call it Corad 5. On the third day, Early morning paralysis, 6 o'clock, we are given a previous day advice that we'll stop the paralysis at 6 a.m. We stopped the paralysis at 6 a.m. And at 9 or 10 o'clock we came, we saw her, she had a good eye opening, she was good motor power, she was lifting on, obeying orders. So we was very happy that she did not have any part of a brain damage or anything. That was one of our worries, 80% saturation for more than 3 to 7, 8, 10 minutes. So we were worried about it, but she was very cooperative at that day. So we shifted more to pressure support ventilation with PEEP. We started with 16 centimeters of water, and PEEP we reduced to 8. Again, saturation she was holding. Then after explaining to her, we'll go slowly with you. Another period of 4 to 8 hours, we'll take the tube outside. She was really a cooperative woman. That's how I think we escaped and she escaped. Slowly reduce the pressure support 2 centimeters per hour. To at last we came to 10 centimeters of water. Vitals were stable. Then under controlled environment, full suctioning, everything done, and she was extubated. Post-extubation also, she was hemodynamically stable. Vitals were, pulse rate was 84 and 120/70 was her BP. Respiration SpO2 was 96 with ventimask of 6 to 8 liters. And the day 4 saturation went up to 98. We shifted from ventimask 6 liters O2 to nasal clocks 2 to 3 liters. Injection remdesivir was continued for 5 days. Steroids, antibiotics were continued. On the day 4, we Norepinephrine, which was tapered to 1 ml, we slowly stopped it. Lasix was also stopped, reduced, tapered to 1 milligram per hour, and we stopped it. On the day 2 only, we were feeding the baby with the expressed milk, and the day 4 after extubation, we gave the baby to her, and she started feeding. Arterial lines and lines were removed. On the day 5, she was shifted to post-op ICU to COVID ward, and after that, she did not face any problem. She was discharged on post-op 7th day with following advice, the same drugs which was taking before, Prolamet, digoxin, Pentads, and Amiflu half OD. And we told her, we talked to her and said, any small trouble, any distress, please come and get yourself admitted. And we advised a review after 1 week in OPD. She came after 1 week, very happy. The whole family was very happy. We saw the baby pediatrician. Absolutely, we escaped from a big problem, I believe. Thank you. And even though this is my last slide, this is not my last slide. I think this baby's prayers, I think this is what saved her and us from the problem. Thank you, sir.
Thank you very much, Dr. Nisham. There are volleys of questions from the audience. That is, they want to justify the use of ketamine. Ketamine you have been using.
Yes, sir. Yeah.
One is ketamine, another is
I could not use
noradrenaline.
Yeah, yes, sir. One thing is intraop awareness. To abolish it, I thought about nitrous oxide I could not use. Sevoflurane 0.5 mag, whether it is okay to her or not, I did not know. So BP was falling. Even on noradrenaline infusion, the BP was falling. So I did not have any other choice other than give, I know she is an RST patient, but I did not have any other choice other than giving ketamine 50 milligram first. And we waited for another 5 or 6 minutes, see the heart rate and the BP response and CP rise, everything we were just looking into. Then we gave another 50. So total of 100 milligram ketamine we have given for an RST patient.
Why not
I did not have any other choice.
Morphine?
Morphine, because the baby, we could not take the baby at that time. We were already given fentanyl, 150 microgram fentanyl we have given. So I did not want to give morphine at that point. Until the baby is taken out, I was just waiting, sir. After the baby is taken out, I gave morphine. that with this all trouble, the ketamine did not raise the heart rate. Maybe 10 heart rate, it increased from 100 to 110 or 110 to 120. Just the 10 beats increase was there for the ketamine. BP also, as I told, the BP also did not increase much. Only after completion of sodium bicarbonate, 5 ampoules, that is 50 ml. Slowly, after finishing that, she came out of the acidosis. I think then that's when the heart picked up its muscular power, and it started giving BP was.
Another suggestion from an audience: why not
Yes.
you use dexamethasone? You have not
Dexa?
used it. Dexa.
Dexmedetomidine you're talking about? Dexa.
Yes.
Steroids, sir.
Yes.
Steroid, we know she's a COVID positive patient. And I know we are going to start her on remdesivir. So I just if there is a bronchospasm or any kind of
you use dexamethasone, right? Okay. Then one more question from the box. That is, you use vein circuit intraoperatively also.
No, sir. To start, only during induction time, I used a vein circuit to give 100% oxygen. Immediately after intubating the patient, we connected to the ventilator. Maybe 1 to 2 minutes was there on the veins to ventilate and check, auscultate, and all the stuff. After that, we immediately shifted to ventilator. GE ventilator. It's a good ventilator. GE ventilator with volume control with PEEP. That's how we ventilate.
Then one more question. That is, how effective the newborn is?
As per pediatricians, we talked about, actually the baby is not having an infection, or I remember they're doing a RT-PCR and it came negative.
So what is the one more question for the sake of audience? If the patient is COVID positive and asymptomatic, or there is a mild symptom only, what is your mode of anesthesia in that case? You can go for regional or
maximum number of cases what we have done is cesareans. We have done around 30 COVID positive patients cesareans. And more than 90% of the patients we took it under regional anesthesia, sir. Even though they had some kind of chest, what do you call, crabs or some kind of a rhonchi, whatever they had, we just were going with the regional only, sir.
Thank you.
My choice for anesthesia during this COVID time is only the regional, sir. We don't want to intubate them. We don't want to
safeguard both the patient as yourself.
Yes, sir. Yes.
Dr. Pankaj, do you have any questions or suggestions? Please.
Sir, one question which is coming to my mind is, why not use phenylephrine instead of norepinephrine? You could have.
We could have done it, sir. We could have done it, sir. But we also do. We routinely use NORAD, the infusions. We have used phenylephrine, but I'm more comfortable using Noradline because that is a drug I regularly use for sepsis or anywhere. We first start NORAD infusion, sir. So that is, I'm more comfortable with Noradline. That's the only answer than phenylephrine. Phenylephrine could have been better because it doesn't raise the heart rate. So we can be more stable, but I'm more comfortable in the usage of NORAD. So I'm sticking with NORAD.
Second, second suggestion from me would have been that when you have taken the patient when you have to cannulate the patient, why not put her on a non-invasive ventilator with higher FiO2 so that she is able to breathe properly, and then do the subclavian vein cannulation rather than doing it in sitting posture?
Yes, sir.
Because that's for us to do, and it will be very challenging to do.
Yes, I when thinking back, and I should have done it all in the cardiac ICU, get everything ready. Then I should have shifted the patient. The thinking back, now to think, but this is a COVID season, sir. To go next to the patient itself, at that time, it was like 3-4 months back we did this case. It is kind of a scary whether we'll get it. And real trouble, sir, real trouble to cannulate and central line, arterial line with whole protection. Glasses, I have a glass, then I have to wear one more glass, then over that the helmet, then the whole dressing, then sterility. It was really horrible thing I had. What you said is perfectly right. First only we should have, in the cardiac ICU only, I should have done a arterial line, I should have had a central line. Before shifting, I should have got everything ready. And this is a COVID theatre, so it's not, we don't take the COVID positive patients in our normal theatre. This is a COVID theatre, which we were using it for very septic and kind of pus patients, a lot of pus patients with pus infection. Those are the patients we are regularly doing that particular theatre. That particular theatre, what we used on that day was not for all the monitors and everything was not there. We shifted everything there, but it's not our normal theatre, sir.
So just, like if we had done that whole procedure in the ICU, you could have
yes,
up
yes,
about
definitely, yes, definitely, yes.
to the patient rather than make the patient sit. So that
Yes.
reclining position, head up position of 45 degrees, then using the the non-invasive ventilator there itself, and then cannulating the arteries would
Yes.
make you easy as well as the patient more comfortable.
Comfortable, yes, sir. Except for the patient's cooperativeness.
Yes.
It's not our smartness. The patient's cooperativeness was unbelievable. She was okay with everything.
A specific COVID lung gets injured while you are attempting a subclavian, then we'd almost lose the patient.
Yes, yes.
So that's why I was a little worried about subclavian. As far as possible, subclavian will not give you much. A central line would not give you much of a use. Even a large bore peripheral cannula is enough to give fluids. We are not going to measure CVP. So the use of putting a central line in such challenging cases, I think, is not required. A peripheral line is good enough. And yes, because you will be giving fluids you will be giving fluids. And if you have to give vasopressors, yes, you may say that you need a central line, but eventually with a large bore cannula, when you give vasopressors, the way it goes into the circulation, the time lag is very less. So that's one thing I would just suggest out of experience, not
Yes, sir. What we regularly do, I am always, sir, I have this routine things to do. This is how I keep everything ready. Mistake was we should have done arterial line and central line in the cardiac unit where it would have been much easier. But always whenever I expect a patient, a septic shock patient or a patient who's going to may collapse or sometimes may have a BP fall, I always start noradrenaline earlier, sir. 3 to 4 minutes prior only, I start my noradrenaline. It is on the flow. I see the arterial line and I see the BP going up. Then only I start inducing. Most of the times I found this as more helpful. So cardiac patients, when you induce, the crash is so much. At that time, giving drugs in IV peripheral line, and it reaching there and getting the response. Rather than that, I have a line which straight in the heart. And the infusion is prior started. It's already started and it is running. Then I go to induce. I've been doing this for past 10 years. I did not have a big crash during induction or anything when I had this. But only thing is, we have to explain to the patient, and the patient has to suffer the injection pain and all those stuff. But this is what I am doing for past 10 years. I did not have much of a crash for cardiac case or septic case because I had an oral infusion prior. So I can easily manipulate from 2 ml to 5 ml to 10 ml. Manipulation was easily been done by me, sir. Anyway,
very much, Nishal. It was a wonderful presentation. You have done an excellent work. It's very easy to give lectures.
Sir, I presented this paper.
When you're doing it it requires a lot of presence of mind and a lot of stability, balance of hands and mind together. You have done an excellent job and brought this very difficult case out. Hearty congratulations to you.
Sir, I wanted to present this case for only one reason, sir. To learn from all of you seniors to know what I could have done better and what more I could, if I'm been ready, I can be saved next time. This is the only reason I present it. Not like saying I did it this way. No, this is a way I did not know this is the way to do it. The COVID positive patient with RST, with patient sitting, not able to lie down. I don't have any experience of doing this kind of a combination. So I actually put this thing forward, and I still sternly believe that it is only the prayer of that baby made me escape as well as the patient escape. That's the only only thing I think, sir.
Thank you,
It's
Nisha.
not my smartness.
You have done a wonderful work, heroic work, and you presented in a very humble way. That is
Thank you, sir.
more presentable than more reasonable for your heroic deed.
Sir.
If there is no other question.
Yes, sir. I have some queries and comments, sir.
Sure,
Sir. Please, sir. Please, sir.
Nishal, it is a wonderful presentation. More than
Thank
that,
you, sir. Thank
more
you,
than the
sir.
presentation, you saved the patient and you did a fantastic job.
Thank you, sir. Thank
Though
you,
there are ifs and buts and comments are there.
Please and tell me that. That's what I'm waiting for. That's why I presented, sir.
Child, no doubt about it. Because patient was in a complete respiratory failure with a circulatory shock. So we completely managed the patient well and saved the patient. Very well done. Well done, Nishal.
Thank you, sir.
What was the echo finding?
Moderate to severe mitral stenosis. Valve size was 1 centimeter, sir.
Okay.
With mild pH.
Okay. Because as already discussed, ketamine, what is the role for ketamine in that scenario was a controversial one. But
Yes,
let us not go into that insight.
When sympathetic outflow is maximal, ketamine doesn't have any role.
Yes.
It has got only anesthetic role. Because already the sympathetic outflow may be very high. Because of all this psychological and physical disturbance. That may be the reason.
The BP also did not increase. Heart rate just 10 rise was what I saw.
Yes, sir. Maybe would have been avoided, but leave it. My big concern is why you used injection metoprolol 5 milligram 8th hourly when the patient is on an noradrenaline infusion in the post-operative period.
Only to reduce the heart rate, sir. Heart rate was 130.
No, understood. How the BP hold it?
No, with noradrenaline only it hold it. Only on the second day, she was on metoprolol XL OD for years. For her rheumatic heart disease and mitral stenosis. So I did not want to stop it and to find out what is going to happen. I just want to continue whatever drug she was continuing on digoxin. She was continued on after stopping Pentix, we went into augmentin, then to plus some antibiotic coverage. Just to continue what she was taking. I don't know whether I'm right in using a metoprolol at that time. I was talking to the cardiologist for everything I'm doing, but he said just continue that. And if the heart rate is still high, we are planning to start her on ivabradine. So that is one. If the BP falls, then I thought, okay, NORAD is what.
That is what I wanted to tell you. Because when the patient was on metoprolol, you can continue when the patient is not on noradrenaline or any supports. Patient is on vasopressor support.
Okay,
better to withhold that any antihypertensive drugs which may produce hypotension.
Yes.
In that situation, and you would have gone for the ivabradine to control the rate if it is high.
Yes.
That was my suggestion. So whatever it is, you managed well and brought out the patient and the child very well.
Yes.
And one
Dr.
more.
Kumar, can I add one?
Yes, sir. Yes, sir. Please, sir.
Yes, sir. See, what I can tell you is that you said that ketamine, the heart rate didn't go up. Now, if you recollect, you will know that the patient has been on metoprolol, and that's why the heart rate didn't go up. And you were able to safely use ketamine here. So it was an absolute good choice. I do not know how it occurred to you, but when I look back at the case, I think you made the right choice. Even I would have used ketamine if nothing else was working. And there is no issues of using ketamine in that doses with norepinephrine. We very commonly use ketamine and propofol infusions to sedate patients in ICU when they're on vasopressors and when they are really agitated. So that's a perfect thing, not an issue. But yes, 50 milligrams was a good choice. And the reason you didn't get that rise in heart rate was because the patient was already well beta blocked.
Yeah, maybe so. Maybe so. And
Yes,
good dose.
definitely. There is no contraindication for ketamine, no doubt about it. And there is a hemodynamic compromise, better to go for ketamine or keto fall, all those things. But that is well understood. Regarding one more thing, in COVID, we usually the evidence is supporting for steroid is methylprednisolone or dexamethasone. So those things and all in the post-operative period. I don't want to go into the COVID management at this time. There are any questions, we can proceed or we can.
Yeah, well done, Nishal. I think hearty congratulations to your entire team. I think it is a great experience for your entire team. And we know that you're all doing so many cases, COVID positive cesareans. I think it will be, you would have become experts by now. And what's your general protocol for these things? For COVID protocol, just briefly, quickly, you can enumerate. Nishal?
Nishal?
Yes. Nishal, are you in the line?
Yeah, unmute, Nishal. Nishal, please unmute.
Yeah. I know you mentioned about PPE, mentioned about this thing, and what about your filters at the patient end and all those? Briefly, quickly, you can enumerate so that people will be sort of highlighted again. Yeah, we are able to get now.
We are able to hear. We are able to hear, Nishal.
Yeah. Nishal, we are getting you.
Okay. Right.
Hello?
Yeah. We are able to hear. We are able
sir. Sound mute type, sir.
Did you get the question, Nishal?
Sir?
Question.
No, did you get the question? No, first probably went offline at that time.
Offline, sir. 1 second, sir.
Right. We congratulated you for the excellent presentation and experience your team is gaining in managing COVID positive cases, and you would have become experts. Briefly, quickly, you can enumerate your COVID protocol for, especially for GA, because you said these patients, there no choice other than to go ahead for a GA. So what's your quick summary of your COVID protocol to prevent your team getting safer outside without cross-contamination? By the way, anybody got positive after this case? Because this patient had to shuttle up and down. A very lucky team. I think you are very lucky on that.
Well, we have been doing more than 30 positive LSC cases we have done.
Right.
We did not get any one of us became positive because the full PP plus 3M N95.
To tell what's your policy or what's your protocol, because with so many cases, none of you have become positive. So you should give the confidence for viewers that if you use that, you are also quite a bit safe. Just to highlight once again.
Sir, my personal belief may not be as everybody may not accept it. My personal belief is you wear a proper mask. You cover your nose and your mouth and wear a glass, cover your eyes. You cover your face, very good, take a good protection. It itself is, I think, more than enough for COVID, sir. You don't have to really wear a PPE is what I personally believe. But our hospital policy is anybody going into a COVID theater has to wear a full PPE. All the patients are covered with blanket and things with a mask, oxygen mask when they reach the theater. Then we use all disposable sheets. We don't, no case will have a repeat, the cloth things and all is gone. intubation, we tried that intubation box for some patients, but I personally could not intubate with the intubation that box. My juniors, my friends, they were intubating with it, but I don't know, with glasses and becoming older, and I'm not able to really intubate with that intubation box. But extubation, definitely I'm doing it with the box.
Yeah, it's not about that.
Always I keep the bar inside and put suction through and through. That's how I'm extubating the patients. But very minimal cases, positive cases, we did it under GA, sir. It is only spinal we are doing. Full PPE with full sterility, give up a spinal and make them lie down. If you are using GA, we use filters, sir, both sides, patient end as well as the machine, and bacterial viral filters are we are using. That's the only thing. Full PP, sir. You should see me in full PP. Already I'm too huge, and in a full PP, you should see me like I'm like a big, fully covered
Teddy bear.
scary looking.
You're a big man.
Good, good. Well done, Nishal. I think we'll over to Kumar and to Kripa to continue the rest of the proceedings.
Thank you, sir. Thank you.
Karan sir, anything?
Sudarshan, one
No,
second,
no, sir.
Sudarshan.
Thank you very
Kumar.
much.
Yeah, yes, sir. Please, sir.
We have come to the
Vishal.
conclusion.
Muthukrishnan sir,
Krishna want to add some.
please,
Vishal,
Krishnan, sir, coming, sir.
superb பண்ணிட்டேன். So
Thank
very
you,
done.
sir.
The only one thing, my question, your background is very clean. I think nobody touched the books.
Illa, sir. These are all.
Library.
I'll just show you the photos. These
Please,
are all
please,
there.
yeah.
Over 20, 30, 40 years old books are all there. New books are also there. But
Very
it's
good.
from Dr. Jayasekaran. Some of the surgical books and all, like it's like 1940s books and all will be there.
Very good.
Big collections, sir. Huge collection.
Superb. So,
This is third generation of hospital they are running, sir. Third generation are running.
Good.
Dr.
I think
Kumar,
over to Kumar.
கிருபா சார் இவரு ஏலம் சார் பேசணுங்கிறாரு.
அதான் 1 minute. நீங்க first academic session முடிச்சிருங்க.
இல்ல
Regarding the topic or something else? Regarding the topic?
இல்ல he wanted to talk, I think, about the topic.
Yeah, we can allow.
Unmute him and let them question.
Yeah, please unmute him. அதுதான் கேக்குறேன்.
Shilpa,
yeah.
please unmute
Shilpa, sir.
Dr. Sundaram.
Sir, ஏலம் sir, please unmute and come.
Name?
Dr. Meenakshi Sundaram. A.L. Meenakshi Sundaram.
Yes, sir, please, sir.
Unmute yourself, sir. Meenakshi. Yes.
Nishal,
Yes, sir.
it was very well done. But see, whenever a difficult case like this comes, the questions will be phenomenal and everyone will have their own way of doing the case. That's what I wanted to tell you. But personally, I feel that just for a nutshell, I'm saying only one point. I think there is so much of a polypharmacy, which I will call you by night. I will talk to you personally. That is one point. But I want to ask one question. You have mentioned some non-rebreathing venti mask. What is that? Non-rebreathing venti mask.
Sir, non-rebreathing venti mask. The venti mask, sir. Below that, they will have a bag.
No.
Have a bag.
That's not, Nishal.
Sir.
See, I think, see, there Hudson mask. I think you are mentioning Hudson mask as venti mask.
Okay,
Venti
okay,
mask
sir.
is that is the reason why there is a confusion. See, non-rebreathing
yes.
mask everyone knows. So it's so you are
Yes,
saying
yes.
non-rebreathing venti mask. So venti mask is entirely different. So
Yeah.
you check it up. Thank you, Dr. Kumar, for the
Thank you, sir. Thank you, sir. Thank you.
Mask with reservoir, he would have meant.
Mask with the reservoir.
Ask with the reservoir. Okay.
Because that can give up to 100% if necessary.
Venti mask is with the funnels now. It is coming with the different colored funnels. So environment is accordingly.
Yeah.
So I got suddenly confused whether any new entry is there regarding non-rebreathing. That's okay. Right. It is very well done, but man on the spot is the correct judge. I may be having so many if and buts. But see, you have saved the mother and the baby. So even if you have committed anything wrong scientifically, you cannot be held responsible for that because you have saved the mother and the baby. Very good case.
Thank you, sir. Thank you, sir.
Thank you, sir. Thank you, sir. If there are no questions, Kannan sir and Pankaj sir, can we conclude?
Yes, sir.
Yes, sir.
We can continue.
Thank you very much.
Yes, sir.
Thank you.
Thank you, sir. Thank you very much. We had a very excellent both the sessions. First by Dr. Selva, who spared the time and did a fantastic job on fluid management. And next by Dr. Nishal, excellent case management, appreciated by everyone. Thank you, Nishal, and thank you, Dr. Selva. And I especially thank both the moderators. They did a fantastic job. Dr. Professor Kannan sir and Professor Pankaj Kundra sir for excellent moderation. We had a very good session. Thank you very much. And over to Dr. Kripa sir.
Yeah. Thank you, Dr. Kumar, for moderating the session. On behalf of Tamil Nadu ISA, we thank both speakers and moderators for excellency in their job. Now, I want to recognize the presence of Dr. Gurudat, Professor of JSS Medical College, Mysuru, and our past National Vice President, Dr. A.L. Meenakshi Sundaram here. Thank you, sir. And
Sir, now also.
Yeah.
Dr.
Now,
Kamesh, past president, is also there.
Kamesh Rao is here. Okay.
Yeah, yeah, Professor Kamesh Rao.
I want to make another final announcement here. Regarding the credit hours, please note down this number. You send your name only to this WhatsApp number. We will send you the Google form and the bank account details. You just fill the form and submit it. We will get all the details about you and we will proceed with the credit hours for you. Don't send the name or MCA number, anything by SMS. Send your name alone only through WhatsApp only. Okay, thank you. And now I invite Dr. Rajashekhar, Dynamic Secretary of ISA Kanyakumari, to give his branch report. Dr. Rajashekhar, please. Yeah, unmute yourself. Yeah.
Good afternoon, everyone. Greetings from ISA Kanyakumari. I'm here to present the Secretary's reports. In this COVID period, we did a lot of work and then earned little money for our ISA branch. We procured some intubating hoods, face shields, around 1,500 PP kits, and N95 masks were procured and supplied to all ISA members at nominal cost. Thank you, sir.
Thank you, Rajashekhar. Next week, the program will be hosted by ISA Vellore. So we have already received the topic. Both are excellent topics. So I wish all of you to visit again on the same day next week at 11 o'clock. Now I invite our State Treasurer, Dr. C. Ratnakumar, to give his vote of thanks. Dr. Ratnakumar, please.
First of all, I thank the speakers, Dr. Selva Panchashram, who had presented an excellent presentation, getting up early in the morning today and giving an excellent presentation today. It's a very challenging topic. We always get confused with fluids, sir. What fluid to put for what patient is always a question all the time. And you answered at least 75% of my questions with your presentation, sir. Thanks a lot, sir. Thanks for sparing your time. Thank you, sir. And next, I thank my best friend, Dr. Nishal, for his excellent presentation, who is a brave anesthesiologist. And I will boldly say he is the best, at least I know in my town, who has served lots of lives. And this is just one among them. And I thank a lot for his excellent presentation, as well as his management that saved the patient's life, as well as the baby's life. Thanks a lot, my best friend, for your best presentation and for teaching me something also. If I get into some situation, I'll have some confidence at least to manage such a patient. And next, I thank the chairpersons of today, Professor Pankaj Kundra, which we all know well, who is an excellent academician as well as an excellent anesthesiologist, and my beloved and very respectful Professor M. Kannan sir, who is well known all over India and internationally too for his academic contributions and his practice, which has helped many junior anesthesiologists also And personally, he has helped me also in many challenging situations. Thank you, sir. Thanks for chairing the session. And as treasurer of ISA Tamil Nadu, I thank ISA Kanyakumari, and in particular Dr. Vijayan, who is president of ISA Kanyakumari, and Dr. Rajashekar, the secretary of ISA Kanyakumari, and our past president, Dr. Ananda Kumar, for his kind facilitations. And I thank our vice president, Dr. S. Kumar, for coordinating this academic program. And finally, as member of ISA Kanyakumari, I thank ISA Tamil Nadu for giving us a chance to host this excellent ISA webinar. Thank you, sir.
Thank you. Thank you, Ratnakumar. And with that, we are concluding the meeting. And next day, at the same time, we will meet again with ISA Velour's contribution. They will be hosting the program. Thank you very much. Have a safe.
Kripa also mentioned now today itself, let them. This thing, it closes.
Yeah.
The registration.
Close in another 15 minutes. So before that, you send your name. After that, we will not entertain your entry.
Yes. Okay. Whoever is wanting to get the credit points, they have to send the details now. Your name.
Name only.
Only the name. Later on, if you do, please don't feel bad that we are not included. Thank you.
Thank you.
This is to reduce our academic work burden. Official work. Yeah. Thank you very much for excellent coordination. Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you.
Bye.
Thank you, sir. Bye.
Selva, bye.
Bye.
Bye, Muthu. See you.
Bye.
Thank you. Shilpa, you can close down the meeting.
Okay, sir. Thank you all.